So today we have mostly Lindsay Miller speaking about pulmonary hypertension, but just to give background for anyone on the line who doesn't know us, Lindsay and I'm Rose Champagne, are the nurse practitioners who work in the advanced heart failure clinic and inpatient at St. Luke's. And one of the areas that we work in is pulmonary hypertension. We have a pulmonary hypertension clinic at Luke's, and so we see patients both inpatient and outpatient. And so today we're going to try to give you guys some pearls about how to deal with these complex patients and the complex treatments. So Lindsay, I'm going to have you take it away.
Yes, sounds great. So today we're going to talk about pulmonary hypertension. My goal of all of this is to kind of educate you guys about the disease and the treatment process. And as I go into doing that, I'm going to throw in personal anecdotes here and there that I found helpful to our practice in palliative care as it relates to these heart failure diagnoses. So what is pulmonary hypertension? I wanted to start out by defining it, and you guys are perfectly capable of reading this, but in short, it is a remodeling disease that increases the vascular resistance within the lung. So this is really more an issue of blood flow, but it results in an issue of low oxygenation. So it's something that affects both perfusion and ventilation, but by way of mostly the perfusion pathway. The ultimate takeaway right there is that bottom point. It ultimately leads to right ventricular failure and eventually death. This is a progressive disease. This is something that when we're having our conversations with folks, we're talking about how this is something that is not curable. Our goal of treatment is managing it. It's trying to modify our lifestyle, modify what we're doing and how we're doing it, using medications as appropriate to try to get sort of the best quality of life that we can, knowing that this is a progressive disease. Diagnosis is kind of a tricky thing. This is a really tough process, and it's really frustrating sometimes for patients and families. Pulmonary hypertension can be really difficult to diagnose because it comes down to specific and invasive testing. What you see listed here under my preliminary headline, the blood test, the echoes, exercise tolerance test, those kinds of things can kind of point you in the right direction. But really the gold standard in how you officially diagnose pulmonary hypertension is by looking at someone's pulmonary pressures on a right heart cath. These other things that are listed above it can really, again, start to point you in the right direction and help you realize that a right heart cath is necessary to diagnose this. But without that, we don't have a true official diagnosis yet. So as you might imagine, it can take us a while to get to the point where a right heart cath is appropriate. I don't know about the other providers that are on this call, but when I was studying in grad school to be a nurse practitioner, they were saying that one of the very common sayings that they would use is, if we happen to be here located in Wisconsin. So if I'm sitting in the forest and I am having a picnic or what have you, if I close my eyes and I hear hoofbeats, it's probably not a zebra. It's most likely a horse. You have to look for the horse first. You have to assume that that's what's there and look for that first. So when someone is coming into the emergency room reporting shortness of breath or something like that, I'm more inclined to think initially maybe a pneumonia, maybe a COPD, maybe a heart failure, but it's unlikely that I'm looking directly first into pulmonary hypertension. So getting to that diagnosis ultimately can be kind of a long road for patients. When someone is in that right heart cath, they do a vasodilator challenge. They will give someone a calcium channel blocker and monitor their pressures. And if they see enough of a change, which is typically anywhere between 10 and 40 millimeters of mercury in the pressures, they are considered a person who is vasoreactive, which is a good thing because that means your calcium channel blockers that you just used to find that information out can be used as sort of your first line of treatment for pulmonary hypertension. The main point of this graphic is to show you that even in a disease as specific as pulmonary hypertension, it's a type of heart failure, they can even further delineate it. You can split this up as specific as you want. There's 5 different groups of pulmonary hypertension. And the first one, group 1, is actual pulmonary arterial hypertension, blood pressure that is high in the pulmonary arteries. This can come from genetics. It can come from certain diseases like connective tissue diseases, scleroderma, those kinds of things. But any other cause of pulmonary hypertension is caused by another disease. And so that plays, of course, into prognosticating and treating the pulmonary hypertension, because in groups 2 through 5, the symptoms of pulmonary hypertension are really the symptoms of the underlying disease. And treating the pulmonary hypertension is sometimes more about treating the other disease process that's going on that's leading to this hypertension than it is the hypertension itself. So group 1 is kind of different than all the other ones. If it's difficult for you guys to see, I can just let you know. Group 2 is pulmonary hypertension that comes from left heart disease. So it's coming from a backup of fluid causing hypertension in the capillaries. Group 3 is pulmonary hypertension that comes from lung disease. Group 4 is a really special kind of pulmonary hypertension that's called CTEPH. It's chronic thromboembolic pulmonary hypertension. This is really a blood clot group. And group 5 is PH resulting from anything else.
People can also have mixed groups, which makes it even more complicated as far as how to treat them and how many different ways they're being treated. Sorry, Liz.
Absolutely. Thank you. I wanted to provide, for those of you who already have studied this, the quick reminder of the flow. I know this is something that's relatively basic, but just as a reminder of how these flows are all going in which directions, because it's easy to see when you look at something like this of how a backup in one area can easily affect everything else. Your whole body is one closed system. It's like plumbing in a house. And if you have high pressure in one area that goes on for too long, it's going to ultimately affect pressures in the other areas. So for example, someone who has a pumping problem on the left side of their heart, where the number 5 is there on the red side, it could easily back up into the lungs and cause hypertension in the lungs. And that's part of what we're talking about here. Otherwise, you can get it from, again, the other groups of diseases that we talked about on the last slide. I use this graphic with you guys, but when I'm sitting down with patients and families, I like to talk about the flows of the heart and the vasculature in general in terms of either plumbing in a house like I just did, or sometimes I refer to it like a traffic jam, because that's a situation that people can understand pretty well, where you've got flow happening in your veins, you've got cars traveling on the highway, and if you have a backup, it's easy to understand how that could affect areas eventually that are way far down the road. And so I think that's a nice analogy that we can use. People seem to understand it well. In the last slide, I talked a little bit about this one special kind of pulmonary hypertension called CTEPH. And this one is one that just kind of fascinates me. I'd like to talk about it for just a moment. This is a form of pulmonary hypertension that exists because of a blood clot. And you see here, someone has this blood clot on right heart cath. And that's what's all lit up there in the middle. This is obviously something that has led to a huge interruption in their blood flow. And because our blood is what carries our oxygen, that's resulting in an interruption in overall oxygenation. So we have a ventilation problem that really is resulting from a lack of good blood flow, so a perfusion problem. This used to be something that unfortunately we couldn't really do a whole lot about, but they're really making a lot of progress in treating this one. This is what you see here, that blood clot on the right came out through a pulmonary endarterectomy. It's a procedure that we can do for folks who have certain criteria. It can be difficult to do. It's a very long procedure. It can be 12 hours or more, and it does involve open heart surgery. And so this is something that really, your little frail people are really not great candidates for this. This is people who would go through this are folks who are able to withstand a really long surgery and the anesthesia that comes with it and things like that. So not everybody makes a great candidate for this. The other thing to remember about this too is that folks who have clots in the more proximal or farther off parts of their lung, those are going to be really tough to reach and really tough to get out. So really only a few people can meet the criteria for this. But if you do, this is actually one way that this group of pulmonary hypertension can be cured. This is really the one that can be cured. So this is a really important procedure for those who qualify for it. or for those who meet the criteria. Once this clot is removed, actually, and we let things kind of go back to normal, it can help normalize the pressures back to where they should be. So again, back with the, this is the one type that under the right circumstances can actually be cured. Talking a little bit about prognosis. Prognosis is really, really difficult in these folks because oftentimes we don't see pulmonary hypertension happening on its own. As you saw, most of those World Health Organization groups that we talked about earlier are a result of other diagnoses. And so this, what you see here is a calculator. And this is just an electronic version that it can be easily used on a smartphone or something. And that's why the formatting looks the way that it does. But this came from the treatment algorithm, basically from pulmonary hypertension. And if you look up the treatment algorithm, it looks more like a flow chart, but this is just a little bit more screen-friendly version. So I wanted to include this one. This is a calculator that we use to help determine what someone's certain risk category is. And based on their risk category, we can figure out what medications are most appropriate for them to be on. This does not necessarily tell us, their risk of mortality in the next several months or years or anything like that. It simply places them in a group of high risk, moderate risk, low risk kind of a thing. And you can make prognoses based off that. But again, going back to a few slides ago, someone who has pulmonary hypertension, that's any of the groups 2 through 5, where it's basically a symptom of another problem. Your prognosis is going to be more related to what that other disease process is than what the pulmonary hypertension actually looks like. So I hope to not get too far into the weeds on this one, but treatment, basically, if your first thing you want to do in clinic is put someone through a 6-minute walk test. And if they do okay on that, you can continue to monitor them without therapy. There's no need for drugs at that point. For patients who are symptomatic, we start with these medications. First is the calcium channel blockers if they were vasoreactive on the right heart cath. And then we get to these ones that I've highlighted in green, all of the next ones here. These are targeted therapies. These are really highly specialized groups of medicine that have really been explored a lot more deeply in the last few years. So they're newer, and as such, not all of them are generic yet, which is one of the barriers we'll talk about. So based on someone's calculated risk, you can figure out how many or which of these medications should be used. The first group that I have there is the endothelin receptor antagonists, and these basically work by reducing the endothelin, which is an enzyme that causes constriction. So it basically relaxes the vasculature and helps relieve the pressure in that way. The one thing to keep in mind with these is that you have to monitor someone's liver function. These are oral medications, so there's low burden, but they are not generic yet. The next category is the phosphodiesterase type 5 inhibitors, or PDE5 inhibitors. These two are oral. They come in pill form. PDE5 is an enzyme that causes vasoconstriction. So again, we're working on increasing the flow by helping the vasculature relax a bit. These are, again, oral meds, and some of them are generic now. So this is a common one that we see nowadays in the clinic and whatnot. Side effects to watch for these come from the effect, right? These are oral medications that cause vasodilation. So you're going to see the vasodilation in places other than just the lungs. You're going to see that elsewhere as well. You're going to see symptoms of things like headache or facial flushing. Patients might get lightheaded. Sometimes these medications can be initiated while someone is inpatient just to help monitor for that and treat those side effects if they do occur. But oftentimes what side effects patients do have can resolve within a couple of days as their body sort of begins to tolerate the medication. Similar to the next category here, the SGC stimulators. This is the first line of treatment in someone who has CTEPH, that clotting type, WHO group 4. It helps to slow the progression of that. This is an enzyme that causes dilation, and these stimulate that. So instead of reducing constriction here, we are stimulating dilation. And so thereby we're having kind of the same effect. These cannot be taken with the last category we talked about, the PDE5 inhibitors, because they have a similar mechanism of action, and they would they would cause too much complications. So again, similar kind of mechanism of action, similar side effects. You see some low blood pressures, you see some headache, you see some facial flushing, some lightheadedness. And again, people can start to sort of get used to, as their body acclimates to having the medication, the side effects tend to go away in a couple of days. So we can use things like over-the-counter Tylenol and things like that to treat things like the headache and whatnot. And generally, patients choose to, we usually approach them and say, what do you want to do about this? If they start to have, for example, a headache, let's just use that for conversation's sake. We approach them and talk about what our options are. At that point, we can, if we're up titrating their medicine, we can stop where we're at and kind of leave things where they're at for a couple of days and see if the symptoms improve. Or we can come back down one step or something like that, or we can continue to treat their side effect with over-the-counters and see how things go over the next few days.
Patrick, did you have a question? Oh, you're muted.
You mentioned about the 6-minute walk test. Is the symptoms, is that shortness of breath or angina, or what are we looking for?
Shortness of breath primarily.
And stamina and fatigue. Can you get through?
The last category that I wanted to talk about of medications was the prostacyclins. These are really cool and they're really, really specific, but they're really, really complicated and they make our job difficult sometimes. You can have these in IV or inhaled forms. So these come as inhalers, these come as IV. When they are IV, they are given over a 24-hour period continuously. This is not something like a IV antibiotic where you would hook yourself up 4 times a day or something like that. This is something that when someone chooses to go on this medication, they are on it and they're on it all the time continuously. They have a very short half-life and someone will start to feel symptoms sometimes in as short as a few minutes, honestly, if they come off of this medication. So things like showering and getting dressed and things like that become suddenly a lot more complicated. Patients who tend to have advanced stages of pulmonary hypertension where they need these medications may also have advanced stages of other diseases too that can complicate that and make mobility difficult anyway. So definitely something to keep in mind. It's complicated. When someone goes home with an IV medication that is going to be continuous, they go home with an IV pump. And they need to know not only how their medication works, but how the pump works. So someone who's not technologically savvy or not comfortable learning new technology, that may be a barrier to this. And in addition, they need to have a good support system, people who are available to help them when it comes to things like dressing changes, or even sometimes just connecting the IV and things like that. And also these medications, when it's through the IV form, they're not very shelf stable. Once they're mixed, they usually last about 48 hours or so as a maximum. And so they actually come in 2 different components and you put them together and mix them. So someone who is on this medicine needs to have enough dexterity to be able to mix their own medications every day, every 2 days kind of a thing, and then connect themselves. Rose, I saw you unmute. Do you have something to add before I go too far into this?
Couple things. Number one, oftentimes when we get involved is when patients get to that 3-drug. That's kind of the maximum amount of kind of drug interventions. You will see people on 3 of these different types of drugs. When they start to not tolerate them, or if there is a situation where they have to go down from those 3 drugs, oftentimes that's when the PH clinic will start to get us involved because the options are becoming more limited. And in regards to the prostacyclins, the PH providers take very good care of looking at people's whole picture, whole psychosocial situation before they put people on these, because they really are, you have to know what the heck you're doing with the mixing. And they usually have a specialty nurse who trains and all of that good stuff. But you do have to have a support system. And thankfully, the providers are looking at that before, it even gets to that point.
Yes, thank you. Yes, it also, since we're talking about the complications of these, let's go into facility placement. If that's ever needed, that is really, really complicated. These medications, especially the IV prostacyclins, are newer. They're very expensive. They come from a specialty pharmacy and patients get them shipped to their house and they are distributed at home. There's a lot of barriers to providing them within a skilled nursing facility or a rehab center. So one thing to consider when thinking about putting someone on these is what is the likelihood of needing that level of support in the near future? Because for example, let's say we've got Betty who's 72 and a spry 72 doing pretty well. We have no problems with, thinking that she could mix her own medication. She's got a good support system at home and things like that. If Betty's husband dies and Betty falls the following year and needs rehab, she may have her support system might be lower than what it was prior. And the fall might mean that she needs rehab or something like that. We might be faced with a really difficult decision about what to do about this, where Betty either has to go home and get rehab at home, even though a skilled nursing facility for rehab placement would be the best place for her to get more in-depth kind of physical therapy, or we may have to choose to wean off of the IV prostacyclin in order to have her placed at a rehab facility. And when we wean down on that medication, we can expect that we will probably have side effects and that may cause a whole cascade of problems. So we need to be really cognizant of that. And oftentimes we're talking about this when we start the medications, especially if Rose and I are involved in those early stages of starting these medicines. Do you have anything to add to that part, Rose?
Yeah, I'm not sure what your next slide is, so I don't want to be that person who preempts your next slide.
my next slide is talking about hospice care. Is that where you were going to go with this?
No.
Okay, go ahead then.
The side effects of these IV prostacyclins can be really, really serious. A lot of diarrhea, jaw pain, myalgias, nausea. So that has to be, that's a really big piece of this.
Yes.
So, and I'm going to, as far as Marty's question, as far as expensive, a year of Remodulin, which is one of the IV prostacyclins, which also these IV prostacyclins, this is the gold standard.
Mm-hmm.
If you can get on one of these, this is like the big guns, $250,000. So these meds go through a very interesting process. We have one person who deals with all of this. There are grants, there are calls back and forth with, insurance companies. The approval processes can take 2 weeks. So it's no small shakes just getting someone on these drugs. And then you have to figure out if they can tolerate them. And so we do this inpatient. We do not start an IV prostacyclin as an outpatient. They're admitted, they slowly titrate up, and truly you are getting as high up as you can until people start having side effects that they can't tolerate. And then you come down.
As they go on with the medication, let's say months or whatever down the road, their pulmonary hypertension may progress to the point that we're always titrating the medication to their needs, right? And if the disease progresses, we may need to titrate up a little bit. All of these side effects that we've been talking about can happen all over again when we turn up their medication. And they hang on to those side effects, usually for a couple of days, but sometimes people do find situations where they can't shake the side effect. They just can't get rid of it. They don't acclimate to it the way that they did before or something like that. And we can't reach their goal rate on these medicines because of side effects.
And so sometimes that's a discussion of,
yep.
Are you okay with the diarrhea that you have because you're breathing better? Or so that's a lot of those types of discussions as well, because the side effects, the lifestyle change, these are not small things for people. Not to mention, there's also the fact that you have a Hickman line and infection. in your line is a really big deal. So these are the types of discussions that we end up having are, what are you willing to put up with? And then the unfortunate part is, because these folks have been told this is a real lifeline. I mean, some people live 7, 8, 10 years on these meds.
Mhm.
If they're a lifeline and at some point we say, they're not really helping, or this is hurting more than it's helping, and we want to titrate down or get you off of this, I think for our social workers, chaplains, and palliative providers, that's a big deal. You have to talk about what that med means to them, on a larger level. If they've been told that this is keeping you alive and keeping you feeling well, how do you get past that when we've said you need to turn that down or we need to take it off? Because the other thing is, these are also very weight dependent.
Mhm.
And so you can see toxicities very easily too, if you have disease progression, and of course, then maybe some cardiac cachexia. So it gets very hairy. There was a question, I think, from Maureen. Maureen says, I would say that someone who is functionally impaired by their shortness of breath would have much difficulty with some of these side effects.
Absolutely.
Yeah. And, they'll put someone on, myalgias are a real big thing too. And the jaw pain and headaches. And so, I mean, pain with shortness of breath, turns out, there's a lot of balancing and jockeying. And so we work really closely with the PH providers when there are people who maybe aren't tolerating these meds as well as they hoped.
Yes. Anything else to add on that, Rose? No.
I could talk all day about it.
I know, right? I keep thinking of more things. But nonetheless, let's talk a little bit about transitions, end of life implications. There's a lot of coordination necessary, especially for folks who are on these targeted therapies. Again, a lot of these targeted therapies are not generic. They are quite costly, and they're not really offered under a hospice plan, regardless of where the patient is. So we've kind of found a little bit of a workaround in that patients who are going home on a hospice plan, sometimes we can help them order their a 30-day supply is typically what they get from the pharmacy, because remember, it comes unmixed and they have to mix it together. So usually they will get about 30 days at a time. And oftentimes when they're hospitalized, they have to order a new batch, if you will, of a 30-day supply when they discharge from the hospital, and that's delivered to their door. So oftentimes we can try to coordinate with their pulmonary hypertension team, including their specialty pharmacy, and see if we can get a new supply delivered to their house if they're running low. And then we work along with the heart failure team, the pulmonary hypertension team that follows them, to sort of make a weaning plan, if one is appropriate for that patient, of how do we do this over the course of the next few days or weeks or whatever kind of prognosis this person may have, where we can have them on perhaps a lower dose so that it lasts a little longer, using our resources wisely while they're on hospice care. Certainly, yes, in hospice, we can add medications that help with, air hunger, shortness of breath, those sorts of things. But you never want to just stop these medications cold turkey. You don't want to just stop an infusion of IV prostacyclins or something like that. You want to come down off of it. Even if your goal is to eventually get off, you want to do it safely. And so hospice will usually involve the downward titration of their IV infusion and the upward titration of the use of other medications.
And timing is important. Do not enroll them in hospice before you have that med in your little hands.
Yeah.
Because that gets very sticky. And you really have to investigate what is possible. We have had that where hospice will say, oh, sure, we can take that, but they've never even heard of the med. And so, you don't want to get a patient stuck. You don't want to get a patient on hospice where they're like, great, I've made this really big decision. And then they find out they have to choose between hospice or this medicine. So a lot of this work should really be done preemptively when people are maybe having more hospitalizations or having more side effects, because this is not a, we'll get you off this med in a week. Some of these people are on doses that take months to titrate down comfortably. And we've definitely had people stuck in the hospital who don't have anywhere to go.
And also part of the algorithm, the flow chart kind of treatment that I was talking about earlier, one of the very first steps is once you've diagnosed someone with pulmonary hypertension, the next action is not a medication, it's get them to a specialty PH treatment center. And we happen to be one of them, and I think one of the only ones in the state. So we see folks from all over the place. Just a couple of weeks ago, I had a guy from 2 hours away from here. And the complication with him was that he was on unprecedented levels of this IV medication. I've never seen someone on this high of a dose. And so the complication was, of course, when he reported to his emergency room, small town emergency room, they sent him right here because we are his treatment center. The problem was he was acutely dying here in the ICU, and he was 2 hours from home. And with COVID visiting restrictions and things like that, there was many layers of complexity. And luckily, this guy actually started to improve well enough that he was able to get home. And when we sent him home, we sent him home with, he didn't want to be on hospice quite yet because it was too complex with all of his medication changes. So the smoothest thing to do was to send him home with a palliative care strategy and notify the local hospice agency that he was home and he'd be calling them soon. And the plan was, when things get bad at home, if you come into the hospital, you're going to get shipped here 2 hours away from home. You can just expect that. And if you don't want to die 2 hours from home, we have to have the hospice agency aware of you, and you need to call them instead of 911. And so a lot of these plans are really patient specific. This was one of those cases where it was just, if he reached out to what would normally be the proper channels, he'd kind of get sucked up in this whole cascade that would lead him to the wrong pathway. And that's where Rose is coming from, where you have to gather all of the information and really look at what is the big picture here, not just what is the diagnosis or what is the medication we're dealing with. What are all of the external factors that are at play here too?
And all the players, because even though the specialty pharmacy, the specialty nurse that comes out and teaches people about this stuff, they can be helpful. So, I would say above all, reach out to as many people as you can.
And the pharmacy folks will come out and teach the hospice how to use this medication. So that's a resource even for someone who, as we're used to, when they enter into hospice, it seems like some of the resources just go away sometimes. And this is not one of those cases.
I think my biggest takeaway would be ask as many questions as you can.
Absolutely.
I think the tough part with some, and we see this in a lot of disease states, where we go on this path full force and then we're 10 steps down the road and we haven't talked to the patient or asked a lot of questions, and we find ourselves in a position that it's a lot, you have to be really creative to get where you need to be, if that makes sense. Rachel asks, is there a general prognosis for pulmonary hypertension from initial diagnosis? I realize other comorbidities can greatly affect this.
It's tough because people are diagnosed at very different times, depending on, again, that long cascade that leads to their diagnosis can sometimes be pretty lengthy. And sometimes by the time of diagnosis, they actually have pretty advanced pulmonary hypertension. So it's not like some other diagnoses where, when you find it, it's still early on and you have kind of that predictability. It really does vary. And I don't mean for that to sound like a cop out of an answer, but it can be highly variable. You can use the risk calculator to help determine sort of what risk category someone is in. And there are certain nuances, like, for example, someone who has scleroderma plus pulmonary hypertension has about a 40% 2-year survival. But that's one of those nuanced things. General pulmonary hypertension from any cause, it's tough to know.
I think also it depends. So like Lindsay said, when do we get to them, right? Untreated pulmonary hypertension, you're looking at months. If depending on how high their pulmonary pressures are.
Mm-hmm.
We usually, with these IV drugs, they really want to see 6 months to tell if they're helping. And that's going to be measured by another right heart cath and just basically seeing if those pulmonary pressures come down. And I think they probably at least want to see it come down 10 to 20 millimeters of mercury. So it kind of depends. And again, we can add drugs, they'll add up to, a total of 3. I've never seen more than 3. I think 3 is kind of the deal.
3 is max, yeah. There's a question here, does echocardiogram do well for diagnosis or tracking? We certainly use them. Go ahead, Rose.
I think for tracking. I mean, I don't think they would diagnose that way.
Mm-hmm.
I mean, the actual workup for pulmonary hypertension, because you do need to know what group they're in, also includes a bunch of, labs for autoimmune stuff. It's actually quite the workup.
I think to point out too, on echocardiogram, you can pick up some of these chronic changes that occur with someone who has longstanding heart disease, who has longstanding pulmonary hypertension. You see sort of that remodeling and things like that of the heart that if you're treating someone well, some of that can reverse once the pressure is sort of normalized. So if you're treating someone, ideally, if you have optimized their treatment, you may start to see some positive changes on echocardiogram as well.
Mm-hmm.
Great question.
All right, thanks guys. I think my biggest take-home point for myself when I work on talking to people about goals of care here in the hospital is just to be aware of the abundance of landmines that exist in the transition from typical care to hospice care, and just making sure that I stop and I slow down.
I think that's accurate.
Yeah.
Certainly.
And I think that our advanced heart failure team has realized those pitfalls as well when they offer treatments. But, we usually don't get involved until we're halfway down the road.
All right. Well, thank you for your generosity and time today, guys.
Thank you, everyone.
Have a wonderful weekend.
That was great, you guys. Good job.